You can.
Bye.
Yeah. Okay. Thank you for everybody taking the time today to join us for the Reentry Advisory Committee meeting. I know this is 90 minutes out of your day. It's a long time, but this is an important project, and we really appreciate all the responses that we received from the survey from the advisory committee members. And so we will be going over that as well in the slides. I just wanted to introduce who will be presenting today. It will be the Federal Waiver team from Division of Healthcare Financing and Policy, myself, Deidre Manley, Richard McFeely, Bernadette DeMars, and Minden Hall, and Jonathan Figueroa will be running the slides, and Amber Neff will be monitoring the chat box. And we've got our chief, Michael Gordon, on the call as well, who will be supporting us in answering as many questions as possible. We will have a Q&A at the end, and we have a couple slides that we're going to have some engagement, some conversations around, but feel free to put your questions in the chat and we will get to them. If we run out of time today, we will respond back to you in an email. We'd appreciate it if you could put your name and your contact and where you're from in the chat as well, so that we can see who's here and respond and answer any questions that you might have. What we're going to go over to, and we also, Manat is here. I'm sorry, Manat is our partner in this project and keeps us on track and helps us with designing everything as well. So they will be doing a lot of presenting as well today and answering questions. Our agenda today, we're going to be ensuring Medicaid coverage and access to pre-release services. We're going to talk about the pre-release Medicaid application and the suspension process. We'll also talk about screening for pre-release services eligibility and potential uses of capacity funds to support eligibility and enrollment process. Then we will move on to the Q&A and talk about our next steps for our next meeting and what we have going on. I did want to just bring everyone's attention to the fact that there's a lot of acronyms in these slides, and you will see some frequently used ones, which is DWSS, and that is referring to Department of Welfare and Supportive Services. You'll see DHCFP, which is Division of Healthcare Financing and Policy, as well as CF, which refers to a carceral facility. And the acronyms are at the end of the slides, which will be posted within the next week, as well as a recording of this. And highly recommend going back to some of the areas on the recording, even from the previous ones, because this is so much information. And we will put our email address in the chat, as well as our web page where you can go and find any information. Just a couple of housekeeping rules and let's get started. Again, if you could include your name and your agency or whoever you're representing and an email address. This is being recorded, and if you could use the chat or raise hands in the toolbox as well. And if you could please keep your microphone muted unless you want to ask a question rather than putting it in the chat box. And I am going to hand this off to one of my team members, Richard McFeely. Slide.
Hello, everyone, and welcome. So I'm just going to go over a few review slides, basically. Some of this material was already covered in our last meeting on 25th of March. So just to level set and a quick recap, Nevada continues to go down the road of getting our reentry initiative implemented. And of course, there's two pieces to that. And the next slide, I'm going to go over both of those. I get the next slide. Okay, so a quick recap of our initiative currently. So the first part of it is of course the CAA, the Consolidated Appropriations Act, and it is a mandatory service that facilities must provide. It's aimed at children and youth in the carceral facilities. So and that is a mandatory service. And that was started out, that was effective January 1st of this year. The second piece is, of course, the bigger one, if you will, the 1115 waiver, the demonstration waiver. It was submitted to CMS back in December, and we are currently waiting for approval from CMS. So it has expanded eligibility. So it only covers the children and youth. It also covers adults who meet specified health criteria. And of course, held in a carceral facility pre or post adjudication. It also has some additional services that include case management, medication assisted treatment, or MAT. For use for substance use disorder as medically necessary. So it does have some additional services. So again, with this, like Deidre alluded to, please go back and review our slides, or the appendix in this has this laid out more detail as far as these services in more detail. I believe it's actually slide 43. And then you can also go back to our website, and this recording from the last meeting and the presentation is also there for you to review. Next slide, please. So this is a brief timeline of where we're sitting right now with the implementation of the Reentry Initiative. So like I said, the waiver has been submitted. We continue to have bi-weekly calls with CMS, which is more or less known as the negotiation phase. They ask us questions, we come back with answers, and we kind of meet somewhere in between. So we continue to do that. Our team continues to have go throughout the state actually and engage stakeholders in our new process. And also we continue to convene the Nevada Reentry Advisory Committee, which is what we're here for today. So, and then as far as Q3 and Q4 go, a lot of that will be contingent on CMS approval of the waiver. So more to come on all of that. Next slide, please. All right, so basically why we're all here today. These are a couple of review slides as well, but I'll just kind of go through them briefly just to refresh everybody's memory. So the purpose of the advisory committee would be to advise and support DHCFP, Department of Healthcare Financing and Policy, to successfully launch and implement Nevada's reentry initiatives, which include the Section 15 waiver and the CAA Act, the Consolidated Appropriations Act. Membership, and we have all kinds of individuals and agencies representing here, and we appreciate that. Individuals with lived experience, state agencies, prisons, county jails, sheriff's associations, juvenile justice facilities, and the list goes on. There's also at the end of this presentation in the appendix, it gives a list of the agencies and the individuals that we have on the advisory committee. So it's very lengthy, and we're appreciative to everybody who is willing to do this. And the meeting schedule right now, the advisory committee will meet virtually bi-monthly for 90 minutes, of course, to consider various policy design and operational implementation topics. Next slide, please. All right, so another review slide here. Kind of what we're looking for from these meetings in order to maximize everybody's time. Some meetings will enable direct communication and problem solving between Department of Healthcare Financing Policy and key initiative implementers. So the objectives that we would like to see from the advisory committee, and is offer regular input on key policy and implementation issues related to the pre-planning, readiness, and operationalization of Nevada's reentry initiatives, and review and provide feedback on select policy and operational decisions. The expectations: consistently attend and actively participate in meetings, or if you can't, designate a delegate to represent you if you're unable to attend. Review agendas in advance. Keep statements respectful, constructive, and relevant to the agenda topics. Be solution-oriented, offering alternatives or suggested revisions where possible. And of course, represent your cross-reference, your cross-sector perspective. And DHCFP will do their part in as far as preparation for the meetings by circulating agendas and pre-decisional materials for review. So you kind of have an idea of what our subject matter will be. So if you have any ideas, absolutely bring them to the meeting. Conducting and of course conducting outreach to advisory committee before, after meetings to solicit additional input. So with that being said, these meetings are very valuable. And if you ever have any questions, concerns, ideas in between these meetings, we ask you to reach out to us at our mailbox. Send us, questions. We'll answer as best we can, but we want the communication to keep flowing back and forth, and we appreciate that. And even possibly set up a call. If you think we need to call and have a meeting with our team, we can possibly set up a time to do that. So whatever we can do to keep the lines of communication open. And at that point, or at this point, I'm going to turn it over to Bernadette.
Good afternoon. Today I will be providing an overview on how correctional facilities
Say it out loud. Has anybody else lost audio?
Can't hear anything on this end.
a pre-release service delivery. Correctional facilities
We lost audio on the last slide, just so you're aware.
Yes, just a second. I'm trying to get right there.
Yeah.
Okay, this should work.
Okay, here we go. There are key components of the pre-release service delivery. Correctional facilities participating in the demonstration will need to establish processes to deliver pre-release services. First, during incarceration, facilities will assist the enrollment and/or the suspension for Medicaid coverage. Facilities will work with DWSS for enrollment and suspension of Medicaid. And second, correctional facilities will screen individuals for pre-release services. Adults are eligible for a reentry demonstration if they are incarcerated and diagnosed with a mental illness, substance use disorder, chronic disease, an intellectual or developmental disability, traumatic brain injury or HIV, or if they are pregnant or up to 12 weeks postpartum. Next slide, please. Medicaid eligibility and enrollment is a requirement to access services. Having a Medicaid application in place is foundational to provide services in the 90 days pre-release. To be in compliance with federal regulations, DHCFP and DWSS are implementing a variety of policies to facilitate Medicaid enrollment. In order to obtain the pre-release services under the Medicaid Reentry Initiative, individuals must be enrolled in Medicaid. Again, facilities will provide assistance to individuals who are uninsured and assist them with the application process. And for those individuals who are already enrolled, upon entry into a facility, their Medicaid coverage will be suspended, not terminated, so that they do not lose their Medicaid coverage. Both DWSS and the correctional facility will work together to suspend the individual's coverage. Next slide, please. Pre-release enrollment and screening requirements. I think we're on the wrong slide.
Can you go back one?
Go back. Right there. Okay. So pre-release enrollment and screening requirements. Again, to reiterate here, correctional facilities will be required to establish processes to screen all individuals for Medicaid enrollment and a pre-release screening. As we look at part 1 on the slide, facilities must establish a standard pre-release Medicaid application process to ensure eligible individuals can access pre-release services. Over the past year, staff from DHCFP have met with multiple correctional facilities to understand their current processes when screening for Medicaid enrollment. DHCFP will work with the facilities and create guidance on a pre-release Medicaid application. The second component is the screening of pre-release services. Services will be determined by correctional facilities if individuals meet the criteria to receive services in the 90 days prior to release. The determination of services must occur in a timely manner so that benefits can be assessed prior to release, and screening should take place during intake or as soon as possible after intake. The DWSS Craig Road District Office is the designated office to receive and process Medicaid applications and suspensions and effectuate pre-release service eligibility. Next slide. We recently sent out a survey to the advisory committee members before today's meeting to gather input on current eligibility processes in carceral facilities and to find out about their best practices. A list of the pre-meeting questions is provided in the appendix of this slide presentation. We received 30 responses in total from the advisory committee members. As you can see on the graph, we have about 8 categories representing various types of organizations. We also received a couple of responses from the adult or youth with lived experiences. You will also see here within the correctional or justice facility piece of the graph, we received responses from 3 juvenile facilities, 1 state prison, 1 county or city jail, and another 2 facilities that were not specified. Within this group being existing capacity to support eligibility and enrollment varies by type of correctional facility. For example, county jails in rural areas of the state may need the support to build eligibility and enrollment processes to participate in the demonstration compared to other facilities that may already have processes in place. Next slide. On this slide, this represents the correctional facilities feedback from the survey questions. In general, the respondents reported they currently have processes in place to support Medicaid enrollment and may require additional capacity and strengthened communication with our sister agency, DWSS, to meet the requirements. For the purpose of this time, I'm not going to read each line, but please know this information will be provided to the advisory group after this presentation. Next slide. We also receive feedback from partnering agencies outside a correctional facility. Again, a lot of information here, but in general, agencies such as nonprofits, different government agencies, healthcare providers, and managed care organizations say that they currently provide enrollment support, but areas such as best practices, agreements, and communication between facilities and agencies will need to be developed in order to be successful with a demonstration. And from here, I'm going to be handing it off to the MNAT team.
Thanks so much, Bernadette. My name is Allison. Can everyone hear me? No, there was a little bit of glitch. Thumbs up. I see you nodding, Deidre. Excellent. Jonathan, if you could advance us to the next slide, please. And I'll go one more slide. Thanks so much. So as Bernadette was beginning to lay out for all of you, DHCFP, in line with federal requirements, has established a policy to ensure that individuals are able to enroll in Medicaid if they're not yet enrolled, and to have their coverage suspended to the extent appropriate if they already enrolled. So specifically the policy that's upon incarceration, individuals will be screened by correctional facility staff, and if eligible but not enrolled in Medicaid. And again, once they are enrolled, or if they entered the facility enrolled, will have their coverage suspended for the period of their incarceration until the 90 days prior to their release. How this will actually be operationalized is via the steps that are laid out on the screen. And as we move through the slides, we'll walk through each of these steps. So the first step, as we noted, is this initial enrollment screening, where correctional facility staff will assess whether or not the person is already in Medicaid or needs to be enrolled. Step 2 will be offering assistance to the individual if they are interested in applying for Medicaid, and to submit that application for processing to DWSS. And lastly, the third step in the process is the determination of that individual's eligibility to receive Medicaid coverage. While these steps are specific to the Medicaid application process, you'll see throughout the slides that we're about to cover that this ongoing communication and data sharing among correctional facilities and DHCFP, DWSS, so the Medicaid agency, will be ongoing in order to facilitate implementation and monitoring of program requirements. Next slide, please. Okay. So as you'll see as we start to move through these slides, we're going to talk about each of those steps in a bit more detail. And we're going to talk specifically about what responsibilities lie with the correctional facility and what responsibilities lie with DWSS. And you'll see that obviously these entities will be working together across the course of this process to assist individuals with their Medicaid application and enrollment. So for the first step, the correctional facility kicks it off. When a person enters the facility, and we know that there's sort of a full intake process that takes place kind of upon entry or near, the correctional facility will be responsible for screening the individual for Medicaid enrollment, again, during or near intake. Via that screening, if the correctional facility identifies that the individual is already enrolled with Medicaid and that their coverage is active, they will report the incarceration status to DWSS so that DWSS is aware that this individual has been incarcerated, and so that they can suspend coverage for the portion of incarceration until they're eligible to receive those pre-release services before release. If the individual has Medicaid but is showing a suspended status, the correctional facility will report release date information to DWSS, and that's of known. We know that sometimes, particularly in short stay environments, release date may not be known at the outset, or there may be an unplanned release, and so we'll talk that through as we move through these process steps. But we recognize that sometimes the information you'll be working with is imperfect. And then the sort of C option is if the individual is not currently receiving Medicaid, or it's unclear whether they're currently enrolled, the correctional facility will be responsible for asking that individual whether they're interested in applying for Medicaid coverage. And if they take you up on that, assisting the individual in completing and submitting an application to DWSS for processing. On the DWSS side, their responsibility for this initial enrollment screening is really to serve as a resource to the correctional facility and to collaborate with the facility as needed in order to verify that current Medicaid enrollment status and otherwise assist the facility with identifying individuals that may require a Medicaid application. If in that back and forth, the individual is enrolled in Medicaid and the incarceration has not yet been reported, DWSS can obtain those details from the facility. That would include expected release date, again, if known, and as necessary, suspend Medicaid coverage. If the individual is not yet enrolled in Medicaid, then again, DWSS would notify the carceral facility of that current enrollment status so that the carceral facility gets confirmation that they should be moving ahead with assisting the individual with completing and submitting that application. Some operational considerations for this step to keep in mind. DHCFP is working to make their electronic verification system available to carceral facilities to be able to view individuals' Medicaid enrollment status. So right now, carceral facilities don't have a great way, an automated way to be able to check and see if the individual is enrolled in Medicaid. They're going to have to talk to the person, or they would, again, potentially be able to reach out to the centralized DWSS office. In the future, DHCFP is working to make the EVS, the electronic verification system, available to facilities so that they could see that enrollment status information in real time and have a better sense of how to proceed in assisting that individual. DHCFP also intends to work with facilities to develop standardized procedures and mechanisms for exchanging information about individuals' incarceration status and, when available, their anticipated release date on a regular basis. So that may be subject to continued design and engagement with stakeholders. That may be, for example, via a daily inmate roster file, where carceral facilities would be reporting out to DWSS incarceration status of those individuals, and again, when known, their release date. I'll take us to the next slide, please. Please feel free to drop any questions along the way in the chat. We'll make sure that we take some time to address any questions that you may have, or to raise your hand as well to ask a question. So the next step in the process is the actual completion and submission of the application for processing. So again, if that person is not yet enrolled in Medicaid, or it's unclear if they are and they're interested in applying, the correctional facility will be responsible for assisting individuals in the completion of the application and submitting that application for processing. DHCFP, in partnership with DWSS, has created a streamlined paper-based Medicaid application that's customized to the justice-involved population. And you all in juvenile facilities might be familiar with this because this has been rolled out as part of this initial wave of making services available to eligible youth beginning in January 2025. And that's that Form 2970. So the carceral facility would work with the individual to complete Form 2970 and would submit the completed application to a centralized district office, the Craig Road District Office, via email or via fax. Once that's submitted, they would be responsible for communicating with DWIS to troubleshoot the application, to potentially provide follow-up information as needed in order to process the application and move it forward. On the DWSS side, they will continue to provide virtual assistance to the carceral facility in the completion and submission of the application, again, as needed. And then, of course, once they receive the application, they will move forward with processing it and determining whether or not that individual is eligible to be enrolled into Medicaid. Notably, if any of the required forms are missing, they would be responsible for reaching out to the carceral facility to obtain the necessary documentation from the individual. But importantly, this correspondence would be dependent upon the applicant listing the carceral facility as an authorized representative in that form so that they are allowed to receive that information and to provide information back to the Medicaid agency for the purposes of assessing eligibility. Operational considerations for this step include, first, at launch, DHCFP plans to leverage these manual processes, so communication via email or fax, in order to effectuate these processes, but recognizes that as volume grows while the demonstration rolls out, that there may be a need to move towards a more automated process in future years. And so they are actively exploring and assessing options for automation. The other consideration here to recognize, and I know this is something that we've heard both in the on-site visits that Deidre and Michael have been making to carceral facilities across the state, as well as in the feedback we received before the meeting, is we know that it's very different in, for example, county jails, where individuals may be in for a very short period of time. DHCFP's policy, subject to continued design, is that carceral facilities should submit that application as close to intake as possible, given that you have a very short window to work with the individual before they may be released to the community. That said, we recognize that in some of the facilities, particularly, for example, some of the rural facilities, it may be difficult to sort of get that application right at intake, given sort of resource constraints. So again, best practice would be at or as close to intake as possible, and DHCFP will work to continue to specify those timelines for short-term stays. For individuals with longer-term stays, so for example, those who are in state prisons, and where oftentimes a release date is known, applications would be submitted 120 days prior to the expected release date to allow time for the determination of eligibility. And DHCFP may consider additional policy and operational solutions to allow individuals to apply for Medicaid near intake or to work with the Department of Corrections to determine how many days in advance of the 90-day pre-release period those applications would be submitted. Next slide, please. And then the last step in the process relates to the determination of eligibility. So I'm actually going to start us on the DWSS side because this sort of comes first in the process flow. Once DWSS has assessed that application and determined eligibility, they would notify the individual of the outcome of that determination, provide all necessary documentation that would include a notice that the individual, for example, was eligible to receive Medicaid, and would issue relevant documentation. So that would be the benefits card and the person's Medicaid ID number, so they have all that they need to have their coverage in place. The notice of decision would be mailed to the mailing address that was provided on the application. So if the notice on the application address on the application is the carceral facility, and the correctional facility is listed as an authorized representative on the form 2970 on the application, the notice of decision would also be sent to the correctional facility so that they receive the eligibility determination information as well. And then DWSS will also need to ensure, in line with federal requirements, that they are providing the right to the individual to request a fair hearing regarding any adverse actions. So if the individual is not determined eligible, they're given the right to appeal that decision via a fair hearing. And then I'm going to take, so that's sort of, we've determined our eligibility. We're going to send the information both to the individual and the carceral facility if listed as an authorized representative, and make sure that we're able to hear any appeals. On the correctional facility side, the correctional facility would then let the DWSS Craigs Road District Office, the sort of centralized office that will be processing these applications, know of the release date for that individual. They would notify them of the plan release date in order for the eligibility worker to be able to turn full Medicaid coverage back on once that individual is released. If the release is unplanned, the correctional facility would be responsible for notifying DWSS via email within 24 hours of that release and no later than 48 hours, again, to ensure that DWSS is able to turn on the full scope of Medicaid benefits as that person re-enters the community. And the correctional facility will also be responsible for coordinating with the individual to complete a change report form as needed just prior to release to ensure that the mailing address in the community is up to date so that DWSS can continue to send information and communicate with that person as they transition back to the community. And last but not least, on the DWSS side, once they get that information that the individual has been released, they will move to process the individual's case and update their eligibility to reactivate the full Medicaid coverage as applicable. So operational considerations having to do with this step. DWSS is working to ensure it has capacity to process data and effectuate the reactivation of full scope Medicaid coverage on a timely basis. So again, so that once that person's back in the community, they're able to access the full range of services that are available to them as a Medicaid enrollee. And outreach workers and/or correctional facility case managers will be responsible for educating members on how to utilize their coverage pre and post release.
Allison, we have some questions in the chat.
That's great. Thank you so much. Amber, you want me to look at those or are you going to read them out?
Would you like me to read them out to you?
That would be great.
Great. Lieutenant Lorenzo asks, is there an estimated time on the EVS for correctional facilities?
Great question. I'm going to phone a friend at the DHCFP side. My guess is that's still to be determined, but I will just make sure that Michael or Deidre or Vanessa, if she's on the line, don't have a more up-to-date estimate.
This is Michael. You are correct. That is still being considered, and that's why we're having these advisory committees to sort of gather some information and to understand the needs. And yes, we are still working on finalizing that answer.
Thank you, Michael.
Thank you, Michael. Our next question is from Elizabeth Flores. Will juvenile justice facilities receive guidance regarding under what legal authority or exception allows disclosure of youth names? And there's another part, would parental consent be required? And then a comment at the end is governed by NRS 62H.025 and other applicable laws.
Yep.
Let me know.
Michael, I'm going to ask if you can weigh in on this one as well. I know that we've discussed parental consent, and but I want to make sure we're getting it right.
Yeah, we are still trying to research, and we are going to be working with our DAG to work around those situations. We know what CMS's intention is, and we've reached out to them to assist in this process of coming up with an MOU that would work across the board, and that would release that liability on the counties and stuff. So we're still working on that process and trying to determine how that's going to work within the NRS and privacy laws.
Thank you,
Michael.
Allison. That'll last with the questions at this point.
Excellent. And thanks for calling my attention to those. I was moving right through. So thank you so much. Okay, next slide, please, Jonathan. Excellent. So as we noted, and as I know that we've discussed, DHCFP does have a policy in place in line with federal requirements, and that is to ensure that Medicaid enrolled individuals who are released from a facility can seamlessly access services upon re-entering the community. And to effectuate that and ensure that's possible, DHCFP is adopting a non-termination policy. So what that means is that rather than the person's Medicaid coverage being completely terminated, which would then require the individual to submit a new application and kind of start the whole process again to receive Medicaid coverage, Instead, their coverage would not be terminated, but rather suspended, so that upon release, they would not have to fill out a whole application again. That coverage would just be turned back on, and they would be able to receive their full scope of services, again, as applicable. How will this policy be operationalized? So as we talked about, the correctional facility will be checking to see whether or not that individual is enrolled in Medicaid at or near intake. Correctional facilities would then notify the Medicaid agency of that individual's incarceration status and, when known, their release date on a regular basis. So again, potentially via a daily file. For those individuals who are enrolled at Medicaid at the time of incarceration, if the stay is going to be for 30 days or less, Medicaid coverage is not suspended, and that individual will just remain enrolled in coverage. They will remain in their existing managed care plan for that short stay, as long as it's under 30 days. For stays that are longer than 30 days, coverage will be automatically suspended once DWSS receives that release date information showing that the stay will exceed 30 days. And how that actually works is that the eligibility worker at this centralized office will manually update the system to suspend coverage at day 31 on, and as applicable, if that individual qualifies for pre-release services, would activate the aid code that authorizes this limited set of pre-release services. Upon release, as we noted before, correctional facilities will be required to notify the district office of the individual's release, again, via email or fax within 24 hours and no later than 48 hours of release. And once that information is received, the eligibility worker will move forward with processing the case and updating the eligibility, which would include deactivating this aid code that allows them to receive only the limited set of pre-release services, and reactivating the full scope of Medicaid benefits as applicable. So that is the set of requirements specific to suspension for individuals who come into the facility already enrolled in Medicaid. Next slide, please. So I won't take time. Again, we want to make sure we leave some time for discussion, and we're a little bit behind. We just have listed some best practices here as they relate to this pre-release Medicaid application process and across the steps. So we encourage everyone just to take a look at this as you're thinking about how you might be designing these processes and operationalizing them. What are some of the best practices that have been gleaned from facilities in your state and in other states who have experience with eligibility and enrollment processes in a carceral facility setting? Next slide, please. And again, in the interest of time, I won't take too long here. This essentially lays out the process in sort of a scenario-based flow for individuals who are entering the correctional facility without Medicaid. Encourage you all to take a closer look at this slide. It will show you processes both for those people with known release dates. So again, those folks who may be in a longer term stay, such as in a state prison, or individuals who perhaps don't have a known release date. They may be there for a short period of time and their release may be unplanned or just sort of unknown at the time that this E&E process is happening. And then on the next slide, similarly, this scenario will help you kind of walk through a process flow for an individual that's entering the correctional facility already enrolled in Medicaid, and it just sort of puts into place, it's another view of what we just covered in terms of those process steps, but may be helpful to you just to sort of have another view of what this flow might look like.
Allison,
and I will pause because I was going to say, I see some
we have
questions
two more
coming
questions in the chat. Yes.
Yep.
Your first one is from Regina DeRosa. Are the plans to include functionality in EVES to show suspended status on EVES for MCOs, providers, and correctional staff? As of now, offenders show as terminated on our end, and they were actually suspended.
Yep. I will also have Michael weigh in on this. My understanding is that yes, the intention is to explore the ability to be able to show suspended status in EVS for this very reason, because right now it shows as terminated versus suspended.
Right.
Do I have that right, Michael?
That is correct. That's an enhancement that's coming down the line. We don't know when that'll happen, but that is what we're aiming for.
That's great. Great to hear. Thank you, Michael. Because right now, a lot of us are just guessing, right? We can see the incarceration date and see, what did they have before they were incarcerated. So that'll take out a lot of the guessing. So thank you.
Thank you. And our second question is from Angela. And for stays longer than 30 days, will the member be allowed to switch MCO plans upon release? For example, if they want to enter into a specific MCO reentry plan, which may serve their needs better.
Do we have any of our managed care folks on the line? This may be one that we need to take back unless, Michael, off the top of your head. I know that folks are given the opportunity to choose a plan on the application itself.
Yeah, this is Michael. And yeah, there's going to be rules that have to be followed for CFRs on MCOs. So we need to work with, and we can bring this back to our MCO team and get clarification. But there are specific rules that we can't bypass that we need to follow. So more to come on that.
Because as of right now, this is Regina, I'm with Anthem, one of the MCOs. They can't switch if they're assigned to one MCO when they're suspended, right? But they have a right to request a change once they exit incarceration after, is our understanding. But it gets tricky with the suspended ones.
Right. So the same rules apply to what but also the same rules apply to if they're in a family unit, and it goes beyond the complications. So I can't say they can automatically change once they're out. That might not apply if the rest of the family's in an MCO. So there's other rules that have to apply to this. So.
And we'll be certain to take that back. We can send some written feedback on that one to the group.
Thank you, Michael. We have one hand up, Stephen.
I had a question about foster youth. So I'm looking at your guys's form here, and I just wanted to communicate our process in a sense is a little bit different because all of our kids automatically get put on fee-for-service foster care Medicaid, and then obviously it'll get suspended if they're there. But like wanting to make sure that the facilities connect with the social worker, because technically we have a whole eligibility team that will make sure their insurance is put back intact once they're out of the facility. Also, like when we're talking about youth that become adults, they get put on they get put on aged out Medicaid till 26. So a lot of these things that are being triggered, technically, if they're triggering us as workers, we'll make sure it happens. So I don't know if there's a different process or policy with that, because we're a little bit different than just your average young person going into a facility.
And this is Michael. I'll take this. So yes, there will be a policy based off those who are dual eligible, based being in being in the care of the state, and how that process plays out versus those who are not. So we will definitely be working in collaboration with DCFS to ensure that there is no break in coverage and it all gets worked out.
Awesome. Thank you.
Thank you, Michael. And Allison, there are no more questions in the chat.
That was great. That was helpful reminder on the variations across populations. Thank you so much. Excellent. Okay, let's see. Next slide. I want to keep us moving. So these are some discussion questions. I think we have a few minutes for these. And we will open it up for folks to chime in. So just to hear whether or not, and I know people have already been chiming in the chat, which has clearly been very helpful, whether or not there are any concerns that stand out to you around the proposed approach for facilitating these enrollment and suspension processes, or on the flip side, if there's some best practices that you've identified through your work for those of you that are engaged in this that might support the proposed approach to Medicaid enrollment processes. So challenges or potential best practices that you might like to share with the group. And please feel free to drop them in the chat as well, or raise your hand to chime in.
We have one in the chat. Let's see, Brandon Ford. Is it possible to even skip this whole terminating or suspending thing? Why do we do it? They can't use it when they are incarcerated, correct? It just seems kind of redundant to turn it off, just to turn it back on again. Seems like it would reduce a cumbersome process of reporting suspending and then reactivating, etc.
So I will take a crack at this one, and then of course, Michael, please weigh in. It really is in line with federal requirements and relates to oversight and monitoring for fraud and abuse to ensure that once that individual is incarcerated, they're really only eligible to receive inpatient hospitalization. In the absence of this waiver being in place, in the absence of this reentry service packages, federal law prohibits the use of Medicaid for anything outside of these inpatient hospitalization stays. And so it's sort of a simplified version, but it's essentially to comply with federal requirements as they relate to ensuring that these prohibitions on the use of full scope Medicaid coverage or for services beyond that are in place. Recognizing that it does add a number of process steps into the mix.
Thank you, Allison. I have another question. What will be expected for documentation shared with medical representatives for eligibility and/or termination of services?
And Lance, can you say more about that? Do you mean documentation beyond the application?
So yes, there's a couple of references of like sending Medicaid an email regarding change in status or when they're going to be released, and the coordination of the timings of that. And I'm wondering what documentation. We're obviously a juvenile facility and dealing with juveniles, and we're wondering what pretty limited. It goes back to the questions of being able to have consent with releases of information. So the limited information that we can share with many entities, and just wondering what that looks like.
Yeah. Michael, I don't know if you want to weigh in. I know that, these considerations come up across states for privacy and security, particularly when it comes to youth. And so I know that it is sort of a next phase of operationalization. We'll be working out those requirements in more specificity. Michael, I see you off mute.
Yeah, and I concur with what you just said, Allie. Yes, we know that these are issues that are existing, and it's not only in the state of Nevada, it's across all 50 states, trying to determine what's the best practice on this. I know that we are working, we'll be working on electronic health records system that will might help some of this process going down the line. But yeah, there's a lot to learn from you guys, and there's a lot to learn from CMS on how this is going to all come together.
Thank you, Michael. I do have kind of a two-part from Russ Alfano. I believe the first is a comment. The inpatient piece must be applied for in adult corrections. And then he also responded, NDOC has signature authority on behalf of the offender. DCFS may also, and because they are wards of the state.
Thanks, Russ.
And we have a hand up. That would be Mark. Go ahead.
Hello, Allison, can you hear me?
I can.
Perfect. I was wondering if the Department of Corrections have tablets for eligible inmates, and are they able to utilize that to send in the application or communicate via email to make sure everything is complete?
Yep.
I guess I can answer. Typing sucks. I'm sorry.
Thank you, Russ. Hop in.
Yeah, this is Russ from NDOC. Ask the question one more time real quick. Sorry.
One, do you guys have tablets that eligible inmates can utilize to communicate via email and also submit the application, especially if they are long-term incarcerated individuals that have that 120-day post or pre-release timeframe?
Well, two real quick. NDLC, if they're involved in an inpatient environment, we submit, prison medical submits the application on their behalf, and the director of nursing at the institution signs off on their behalf because they are wards of the state, similar to a juvenile institution. I worked in Caliente for 20 years. But as far as the reentry level, once we find out, our OMD, Department of Offender Management Division, notifies Medicaid of who's being released. Currently, we only know 90 days prior to getting out. And we're trying to find a way to claw back to that 120-day mark just to make it more seamless and smoother of a transition. But I know that some of you, ELCO, NYTC, and Caliente all have that remanded to custody thing. So they've got like 6-8 month length of stay.
Mhm.
And I will say it's sort of in the middle of what you had asked, Mark, but and again, welcome DHCFP, or if we've got anyone on from DWSS to weigh in. I think DHCFP's position is that they're going to encourage facilities to use that streamlined form. Right now, the streamlined form is in paper form only. It has not yet been available online. The one that you would access through the tablet, that would sort of be the full Medicaid application. And the thinking is that with the streamlined paper-based form, it's a little bit easier to complete. It's sort of specific to the justice-involved population, and it goes directly to the centralized district office so that they can very quickly identify that this person is incarcerated and sort of know that they need to sort of move quickly and to take into account this release date and have those process steps be operationalized. I do think that for those facilities that for whatever reason have challenges using the paper-based application, the online application may be an option, but I think DHCFP's policy, and Michael, if I'm mischaracterizing it, please do weigh in, is to encourage carceral facilities to really use that streamlined paper-based form so that it's going, rather than going through the online to the sort of general application pile, it's going to the centralized office where it can be processed quickly and in line with these requirements.
That is correct.
Thank you.
Thank you. We have one more question in the chat. Due to the uncertainty of movement in jail, will there be a way to suspend or forward the process to other facilities?
Right. So if they're placed at a different facility, I think Lieutenant Lozano, if it's okay, we'll take that one back and give that one a little bit more thought in the interest of time, unless Michael, you've got thoughts on it.
No, I don't think that's one of the things that we've walked through entirely. So
Yeah.
it's a great
Yeah.
observation. Thank you.
Yeah, good question that we'll give some more thought to. Okay, I see that we're at the top of the hour. I want to make sure we have some time to get to the pre-release screening information, and also to give a little bit of time at the end for some additional discussion. Thank you so much for all of the questions and comments you've submitted so far in the chat. Keep them coming. And I think that I hand off now back over to the DHCFP team to walk us through the pre-release screening enrollment requirements.
Thanks, Allison.
Absolutely.
Sorry, we're all in one room today, and it's a little hard with all these laptops and the speakers. So
sound great, Deidre.
Our next slide, if you can, all right. We're gonna go over the pre-release enrollment and screening and what we're proposing, and then we'll have some questions at the end, just like Allison had on her slides, and then we'll move into more Q&A as well. But thanks, we're getting really good questions, and this is what we want. So next slide, please. All right. So upon incarceration, all individuals must be screened for eligibility to receive pre-release services. And on CMS is their requirements for pre-release screening and services is that all individuals are screened. They state that CMS notes without outreach and support to assist all interested individuals to apply for Medicaid, it is generally and not possible to assess who may be eligible. Accordingly, states must make pre-release outreach and eligibility and enrollment support available to all individuals incarcerated in participating facilities. Coverage and ensure access to the minimum short-term pre-release benefit package to Medicaid eligible individuals identifies as participating in the state's reentry demonstration. So again, we're the facilities that will be participating in this do need to be screening, and then as well as any youth or former foster care up to the age of 26, that is required of facilities. And then our eligible populations. So this is in our waiver, and it was AB 389 that was passed in the last legislative session, defines eligibility criteria for youth and adults to participate in the reentry demonstration project. So adults, their eligibility is who have a mental illness, a substance use disorder, chronic disease or other significant disease, an intellectual or developmental disability, traumatic brain injury, HIV, or who are pregnant or up to 12 weeks postpartum. Once the waiver is approved for our youth, they and aged out foster care between the ages of 18 and 26, they do not have to have any behavioral health or chronic conditions to receive this service. That's after the waiver is approved. All right, next slide, please. All right, so correctional facilities must establish processes to screen all individuals for pre-release services eligibility. And as Allison mentioned, Michael and I and Bill Teal, who is working with us, he's a retired police captain, and our team have been going to all the jails and juvenile facilities across the whole state, and some have these pre-release procedures in place, and so and some don't. So you know, we're learning about that. We're learning all the challenges that many of you are facing out there, and so we're here to support that and problem solve that and help out. So operational requirements. The correctional facilities must screen all Medicaid eligible individuals for pre-release services. So again, under the age of 21 or aged out foster youth under 26 in an adult facility are automatically eligible for pre-release services and do not need to be screened against physical, behavioral, or health criteria. And that is, once the waiver, it goes through there. Adults, DHCFP defines tiered screening requirements for correctional facilities based on the length of stay and the individual need. So for example, in county jails, I'll go through this. We know that in county jails, people can be in there, you know, maybe one night, if that. So we know that is a challenge. It's a challenge across all the states. So we'll kind of go through what these tiers look like. So tier 1, correctional facilities assess for immediate needs, including physical and behavioral health needs, and screen for pre-release service eligibility within a period close to booking. Screening to align with existing assessments that already occur with correctional facilities. Tier 2, correctional facilities that are unable to immediately assess an individual's needs. For example, they're intoxicated, there's not enough time, must conduct a comprehensive screening for health needs and pre-release service eligibility within a defined period. So within 2 weeks of booking. And then tier 3, this would be ongoing. Correctional facilities may identify individual eligible for pre-release services on an ongoing basis. And then correctional facilities will communicate pre-release service eligibility again through that form 2971 that is a paper form to the Craig Road District Office, where these are specific workers that are working with these applications on this demonstration project. And that is how we're going to be able to, there's going to be challenges, there's going to be hiccups. So that is how those applications will go to start with. And that's how that works. Some other things to consider. Given the longer length of stay, prisons may screen individuals for pre-release service eligibility during a time period closer to their release date that still ensures the individual is able to access services for the full 90 days. Another consideration, correctional facility staff may reference medical records to determine whether an individual is eligible for pre-release services. And individuals may also self-attest to having a qualifying condition. Right. So we are going, next slide, please. So we just want to open this up to a discussion, and I think there's probably some questions in the chat too. So let's see. Are there any questions in the chat? Okay, all right, perfect. Okay, let's open this up. Do you have any concerns around the proposed approach to screening for pre-release service eligibility? And you can take yourself off mute if you want and share anything.
Hi, Brandon Ford here. I just wanted to say what my past experiences were in the rural area.
Yeah, I think we have someone.
Can you hear me?
Brandon?
Yes, can you hear me?
Allison?
Yes, Brandon, I can hear you, but I can hear you. Can other folks hear you? Yep.
I was just saying, in my past experiences, that it was definitely in a rural area, and I know like staffing and admin costs were always a concern. Just hearing paper forms and things like that, and a lot of reporting status changes, the screening process, and processing the new applications with Medicaid enrollment. I'm hoping that we can look at IT systems to, kind of smooth out some of these processes, because I think paper forms and streamline just don't go in the same sentence, really. I think eventually we're going to have a problem. We're setting ourselves up for it. And I know Medicaid they just put the new flex system for the provider enrollment and stuff like that too. So, maybe somehow we can get, a system to, do some of this electronically.
Yep. And Deidre, I don't know if you all heard that there will be recording Brandon's helpful comment. Brandon, just to acknowledge, I certainly get it. I think the DHCFP team certainly gets it and really sees automation as where they hope to head. I think there's a lot of considerations just with regard to figuring out those system fixes, finding the funding to be able to automate those processes and the like. But I would say, and then of course, DHCFP, if you're able to hear us and chime in, very much recognize that as the volume across the demonstration grows, there's the potential for this to become a bit more burdensome. And so automation is certainly something that's being, actively considered and sort of on the slate. No promises, because of course, as I mentioned, there's a lot that needs to be put into place, but very top of mind that the future state being automated is sort of where the state would want to be heading on that.
All right. Thank you.
Thank you for that question, Brandon. Yes, Allison, you're correct. That is where we are headed and where we want to be. And while it is going to be challenging in the beginning, this actually will help us to problem solve and kind of see what all the different areas that we can learn from. But that is not how we would want to carry this whole project out by doing it that way. So yes, you're right. Or that's the track we're on. Okay. So does anybody have what are some best practices that may support this proposed approach? Standardized screening process, data transfer agreements. I know you shared some there, Brandon. If anybody else has any. Okay, I'll move on to the next one. And what are the implications to workforce and IT systems? I know we've heard about challenges with the workforce when we're out there. If there's anybody else that wants to share anything or even, you know, an example that they foresee. Okay, let's move on. Next slide. And I'm going to hand this over to Minden Hall.
Thank you for your patience with that. If we can go to the next slide, please. Okay, so we're going to talk about capacity building funds, and they are supported implementation they support implementation partners and correctional facilities planning implementation of reentry services. The funds are a one-time available fund, and the uses are listed there in the blue box on the right. I'll just run through really quick because I know we're running short on time and want to give you more opportunity to talk if you need. So we're hiring of staff and training, development of protocols and procedures, technology and IT services, adoption of electronic health record systems, purchasing of billing systems, planning, and additional activities to promote collaboration. Other activities to support an appropriate environment for pre-release services. So next slide, please. So this slide mentions activities that can be developed and or enhanced existing application processes. The activities that we've come up with are at a point of intake facilities, facilitating the completion of Medicaid applications, transmitting the completed application, identifying individuals close to their release date to enroll in Medicaid or needing coverage reinstated, coordination with DWSS to reinstate coverage or re-enroll, modifying technology and IT systems. If you could, you can either put in the chat or email us if there are any additional activities or ones that you feel that I've mentioned that you don't think that we need. We look forward to your commenting on those. So that was a quick, brief run through of that. So next slide, please. And we will go ahead and open it up again to everyone. You can either put your questions in the chat or raise your hand.
I had a quick question. This is Brandon Ford again. At intake, do they technically still have their benefits if they came in with Medicaid benefits? Could a case manager or a billable provider basically be able to provide that service, that screening in the beginning and that reporting, you know, the status and all that, and actually have that covered? So, you know, it kind of will cover staffing and costs and maybe reduce the burden of the process.
So Brandon, I think we would have to get probably more advice from CMS on that first day status, especially if it's a short stay. I think we'll have to get more. We'll have to converse with CMS and ensure that is possible or not.
Yeah, just brainstorming here, trying to envision how the process would look and the screening and the intake. And thank you.
There are no questions in the chat.
All right, I'm my hands. I'm gonna do it. So sorry.
Good work.
All right. Good afternoon. My name is Kevin Murray. I'm from Silver Summit Health Plan. I do have a quick question. Now that we've talked about kind of the enrollment process and the tracking to pre-release, post-release, as we talk about continuity of care, are there certain indicators or benchmarks that our stakeholder groups have prioritized for continuity of care post-release that maybe we're looking at standardizing for the follow-up components as well? I just ask that because, following some of these programs, we really want to narrow in on what we're tracking. And I just wanted to highlight that as an opportunity for future consideration. Thank you.
That's helpful feedback. I'll just chime in on behalf of the group to say that I think the monitoring approach, both for pre-release services, the provision of pre-release services, and then that handoff to MCOs or community-based case manager and the provision of services in the community are certainly the focus of the program. CMS has been thinking through potential metrics there as part of the waiver approval process and negotiations with CMS. That will sort of come out as well, like what the monitoring requirements are. So I think that's TBD, but it's useful to have on our radars to be able to think through as part of that process and bring it back to you. Any other questions or comments? Forgot our run of show who's taking us to the end here on our next steps.
That would be me. Thank you.
Awesome, Linden.
Next slide, please. We can go to the next one. All right. I wanted to finish this out here saying thank you for everyone's comments and bringing your concerns to this meeting. We appreciate it. So we do have our next meeting, which will be July 29th, and we will be discussing delivering pre and post-release case management. Again, we will send out information on those dates, and we look forward to seeing you then. I thank everyone. Have a good evening.
Thank you.
Thanks,
so much. Have
everybody.
a great night.
Thank you.